ATC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed in the presentation are the views of our speaker and do not reflect the official position of the Department of Health and Human Services or SAMHSA. Next slide. All right, and we are ready to get started. We have an amazing presenter for this breakout session. Dr. Brinen is a primary developer of recovery-oriented cognitive therapy, along with Dr. Aaron Beck. Under the guidance of Dr. Aaron Beck, Dr. Brinen has worked to formalize the treatment recovery-oriented cognitive therapy. He has adapted it to a group model, team-based approach, and milieu. He is a co-author of the upcoming Manual of Recovery-Oriented Cognitive Therapy for Schizophrenia and has been active in the training of community therapists from around the world. Dr. Brinen is an assistant professor in the Drexel College of Medicine Department of Psychiatry, where he directs a center for the dissemination, development, study, and practice of recovery-oriented cognitive therapy for psychosis. Additionally, he trains psychiatry residents in recovery-oriented cognitive therapy. Dr. Brinen is a licensed clinical psychologist specializing in cognitive behavioral therapy for individuals with schizophrenia, PTSD, and other disorders, in addition to training, research, and treatment development. Dr. Brinen also has a small practice where he sees individuals. Dr. Brinen is also a trainer for the Academy of Cognitive Therapy and was a faculty member at the Beck Institute, where he trained nationally and internationally on a variety of topics, including CBT for psychosis and PTSD. Thank you, Dr. Brinen, for being with us today, and I will pass it off to you. Next slide. Oh, Dr. Brinen, we can't hear you.
Thank you for having me. So
there we go.
Welcome everybody. I'm very excited. I actually see some friends of mine from around the country, probably from around the world. I don't usually get stage fright, but to see 417 people coming to see me talk is, that's a lot. So with that, let's get this started. I'm really excited to join everybody today. Again, we're going to be talking in this breakout session about hallucinations, using a recovery-oriented cognitive therapy approach to that. And so again, my name is Aaron P. Brinen. I'm an assistant professor at Drexel's College of Medicine. I'm very excited to be joining Vanderbilt's Department of Psychiatry at the end of the month. So that's a little exciting update for me. So let's start thinking about this, right? What are hallucinations, right? The best way to understand them is that they're perceptions. They don't typically have some sort of like external reason for having that perception. So it could be that you hear something. It could be that you're feeling something. It comes in lots of different forms, right? Auditory, visual, lots of different ones. Auditory are really the most common. We know that. And the interesting thing about hallucinations is that they're not unique to schizophrenia. So a lot of times people just really associate hallucinations with psychosis and schizophrenia, but they're not unique to schizophrenia. And in fact, when we think about it, what we know is about 1% of the population has schizophrenia, right? But what we actually know is that about 8 to 10% of the population hear voices on a regular basis and have no diagnosis whatsoever. And so, and listen, they're sort of butchers, bakers, candlestick makers. They kind of walk around the world and they might just hear a voice talking to them, which is sort of has become an interesting area because we started studying why does a person walk around the world and have no problem versus it's studying only the individuals who are struggling because of their voice hearing experience. When we ask the question, how many people have ever heard a voice at one point in their life, that number can jump up to 60 to 80% depending on how you ask the question. So the take-home message of this is that under certain circumstances, most people can hear voices. When we're talking about things like solitary confinement, we're talking about severe trauma, we're talking about sleep deprivation, times of extreme stress. And just take a moment while we're sitting here, because we're all friends, all 413 of us, you know, has there ever been a time where you were just sitting there and you heard somebody call your name and you just, nobody was there? That was a hallucination. It's sort of this way that our brains have the ability to just sort of misfire and create sound. And so it's an important starting place to go that most people have had this experience at some point in their life, this voice hearing experience. And also, for many people, it's a really normal experience. And so we don't have to think about like, oh, if you hear voices, that means that there's something wrong with you. So we can start with this idea of how do we, what leads to the voice hearing experience, right? Just almost like coming up with this like big equation. And a lot of this is the things that we've all known forever, right? So if I asked you guys right now, if you isolated and stayed in your room, are you more likely or less likely to hear your voices? Or are the individuals you serve more likely or less likely to hear their voices? Right. They're more likely to hear their voices. Or if you're really stressed, are you more likely or less likely to hear your voices? Right, you're more likely to hear your voices. If you sit there and listen for your voices a whole bunch, are you more likely or less likely to hear your voices? Absolutely, you're right. You're 3 for 3, right? You're more likely to hear your voices. So, but all of these factors taken by themselves are things that we're good at, right? We as clinicians. Anybody here ever figure out how to treat stress or know how to treat stress? Anybody here know how to help out with the fact that we isolate, right? Anybody here know anything that works to help with sort of where your attention is focused? Absolutely. These are all like things that we're really good at. And so if we impact any of these things, right? Stress, isolation, attention, and then of course, if you have like a lot of time on your hands, that doesn't make the voice hearing experience any better. So if we address those pieces, then we're more likely, then the voice hearing is likely to go down. So we've taken it from voice hearing, this mystical thing that we need to get a psychiatrist or a prescriber to deal with, and that it's outside of our hands, to something that there are really wonderful targets that we can use. So anything that maintains these sort of 3 pieces that we're looking at here, stress, isolation, attention, anything that's driving an individual to do that is going to be maintaining the voice hearing experience. So we've taken it from something that is outside of our control, and more importantly, outside of the individuals that we serve's control, and now we've placed it very squarely within their control. Which is a really wonderful shift. Because how many of us on this video conference right now enjoy having no control in their life? Anybody here? Is that something that is particularly exciting for people? Not at all. That's not sort of the way that we're kind of wired. We're not wired to sort of be okay with that idea. So when we're thinking about the CTR protocol, and tomorrow I'm gonna, on the keynote, I hope you get a chance to join me because I'd love to have you there. I'm gonna really go through sort of the different pieces of it. But the idea of CTR is this, the idea of the CTR protocol is really about sort of grabbing somebody in and having them engage in the things that excite them more, right? And at those times, we're less likely to hear our voices. And then really identifying those personal, meaningful, valued aspirations, the things that we want to be doing, the things that we want to get in our lives, those sort of big picture pieces. And then at the final thing is just to take meaningful action toward those things that we want in our life. As we do all of this, it creates an experience that allows us to correct the way that we're seeing the world and the way that we're seeing ourselves and the way that we're seeing the future. And so the CTR protocol creates an experience that the individual is able to learn from a little bit more in a really concrete way, We're not talking people out of anything anymore. We're actually helping them to really learn the things that they need to learn. So that the important thing, one of the important things for us to start thinking about is what are the actual beliefs that the individual has about their voices, right? Because from that second slide, we sort of saw hearing voices doesn't cause you distress. Hearing voices doesn't cause you any dysfunction, right? You can walk around the world, right? You can move all the way to Nashville, Tennessee, and hear voices all day long and all night long and be perfectly functional. No problems whatsoever. So what is it that leads a person to have problems, right? And so there's a series of really predictable beliefs that have been identified through research. So the first belief is this idea that of control, that the voices come and go as they please. The next one is this idea that the voices are telling the truth. The third one is that the voices have the power to follow through on the threats that they're levying on you. And so all of these put together, they lead us to engage in a series of behaviors that maintain the problems. Interestingly, and we're going to talk about this a little bit, the idea about whether the voices are a part of your mind or whether they're real people out in the world has very little impact on your actual distress. But the ironic part about it is that belief is the #1 belief that people address when they're looking at, or that many people address, when they're starting to talk about voices. We try to convince people this is a symptom of your psychosis or schizophrenia. It's a part of your mind. It's an overconnection of the Wernicke's and Broca's areas of your mind. All of these things we try to convince individuals of. And that work, at best, will have no real impact on a person's dysfunction, and at worst, will actually lead that person to be less likely to engage in treatment with you. So it's really a not very useful belief to target. So let's take a little bit closer look at each of the beliefs that we're talking about. So I have no control over the voices. The voices come and go as they please. So if I believe that the voices come whenever they want, that I can't control my voices at all, what do I start to do, right? I isolate. But when I'm isolated, you feel pretty nervous when you think that the voices are going to come. And if I had gone out and I had gone to the orientation for my new job, then I would have heard the voices and I would have looked crazy. So then I start feeling more anxious, right? And so then I'm more likely to hear the voices, which confirms the idea, oh, if I had gone out, I wouldn't have been able to stop them. That would have been a terrible thing to have happen. And so ultimately it creates this cycle. I believe that the voices are going to come and go as they please. So I continue to isolate. When I isolate, I'm more likely to hear the voices, as we said before. When I'm more likely to hear the voices, I feel more anxious, right? Which makes me hear the voices more, which leads to me the conclusion. So ultimately, of all the beliefs that you can target as a part of any type of cognitive therapy, this belief is the most associated with dysfunction. So when they looked at what differentiates people who hear voices and have no problems from the people who hear voices and do have problems, the belief that the voices come and go as they please was much more associated with dysfunction than any of the other ones around. So that leads us to the idea that the voices are credible. If I believe that the voices are telling me the truth, right? So think about it. What might a voice be that would do that? So if a voice is saying the FBI is coming to get you and that they're going to come and kill you, right? If I believe that they're telling me the truth, then I listen for them, right? A lot of areas of the country right now are under hurricane warnings, correct? So raise your hand. How many of you guys out there are currently awaiting a hurricane to come visit you? We're not in Nashville, but we're good, right? So how many of you are going to take your phones and turn off your like National Weather Service warning? Anybody? Nobody at all. Right, because we believe that they're telling us the truth. So when we believe that the voices are telling us the truth, there are warning signs. I'm not going to stop somebody who's going to warn me that the FBI is coming to kill me, right? And so what I do as a result is I listen for the voice. But remember, we said if you expect to hear the voice, you're more likely to hear that voice. Nobody on this video, I imagine, listens for things they don't expect to hear. So if you don't expect to hear it, if you expect to hear it, and that's why you're listening for it, you're increasing the likelihood of hearing the voice. So again, we're kind of continuing that cycle. But there's an interesting thing. Think about the last time a friend warned you about something, right? Maybe it was a surprise inspection was coming, or whatever. How many people felt relieved when you were warned by your friend, right? Or even if you were warned by somebody you didn't like that much, but you feel relief that you knew about it. Or think about when you were in school, you were warned about, oh, there's a quiz in math today. You feel relieved that you were warned, right? So the problem is, if I feel a sense of relief at something, why would I start questioning whether it's telling the truth or not telling the truth, right? So relief happens when somebody tells you the truth, which is incompatible with the idea that they could be telling a lie. So when I feel relieved, it reinforces the idea that the voices are telling the truth, which makes me listen for them more, which makes me more likely to hear them, which makes me feel more relieved. And again, we see this cycle is closed. The same is true for some voices that are like telling, sometimes they'll be telling you like bad things about yourself, right? You smell bad, everybody hates you, everybody's talking behind your back. It's not really that you can't shut them up. That's not what the individual's thinking. It's not really that the voices have any power to follow through on the threat. It's sort of like they're trash talking you, but it sort of follows the same pattern, right? So I feel nervous. I want to hear what people are saying about me. So when I listen for what people are saying about me, I'm more likely to hear it, but I feel relief. And then that sort of reinforces the idea of, oh, they're telling the truth, right? This is what people are saying about me, or this is what people think about me. And so again, we set up this really vicious cycle that goes around and around. But again, so we've got two beliefs that we've talked about so far. One, that the voices come and go as they please. And then two, that the voices have the power, that the voices are telling the truth. That leads us to the idea that the voices are powerful, that the voices have the power to follow through on your threats. So let me be clear, and this is going to be a little bit graphic, but if I had heard a voice this morning when I went out for my run that said, if you log into the conference and give this talk about voices, I am going to kill Ella and Jacob and leave their bloody bodies right outside that door, I would have sent the most lovely email to Jen, because she's amazing, right? We'd like give her a round of applause. Raise your hands for Jen and everybody who's organized this. But I wouldn't have been here. I would have sent the loveliest email to them. I love that we got the hands raised up to 25 for Jennifer and the group. But I would have sent the loveliest email. I wouldn't have logged in. No way. Right? Because if I believe the voices have the power to follow through and harm my children, why would I ever show up to give this webinar, to give this breakout session? And so there's two things that people do, right? You either comply with the threat, right? So I do what they tell me to do, right? So I don't log in, or I engage in some sort of ritual, right? So maybe I say the Hail Mary 300 times in a row. Interestingly, when I say the Hail Mary 300 times in a row, you're not hearing your voices, because it's like my mama used to say, Aaron, you can't talk and listen at the same time. Same is true for voices. It's sort of incompatible with it. So at that point, now I'm not hearing the voices, my stress level is going down. But what I conclude is, had I not said the Hail Mary 300 times in a row, my children would have been harmed. right? So it works very much almost like an OCD loop, right? So I have this fear, and then ultimately I kind of, I engage in a ritual that neutralizes the danger. But again, I never conclude that the voices didn't have the power to follow through on the threat. I conclude that, that my behavior stopped the danger from happening, which makes me really scared. You know, listen, I've got great kids. I like them a lot, you know, and who wants to break in a new set of kids? So sorry, that might be a little bit too much. Sorry. So one of the studies, it's an interesting thing because that last belief that we talked about is most associated with individuals who follow through on their threats, right? And who follow through on the command hallucinations. So these great researchers in the UK, led by Max Birchwood and a bunch of some other really great friends of mine over there, did an amazing study where they really targeted that mechanism of action. So the idea that the voices have power. And they found that so they targeted individuals who had followed through on their command hallucinations, had complied with their command hallucinations. And they found that at the end of treatment, interestingly, the individuals continued to hear some of them continued to hear the voices and continued to have the command them saying the commands. They just didn't care because they thought that they were, you know, sort of all talk, no action. And so by targeting that cognitive mechanism, they had a really powerful impact on the actual following through on the threats. Really good study to look at. So the idea of whether the voices are external or not, again, this is least associated with dysfunction. In some really specific cases, clinically, I found that the individuals just remained vigilant. But if there's one thing that we take away from this breakout session, if you take away the idea that this belief is not useful and arguing with people that that this is a symptom is ultimately going to push the person away, and not even if they accept that it's just a symptom of their psychosis, it isn't likely to actually help the individual get any better. So looking toward these other beliefs that they have. So when we're talking about correcting these things, I'm sure many of you on this webinar have been exposed to cognitive therapy, and oftentimes know cognitive therapy as sort of thought records and things like that. What we're going to do in this situation, remember, the experience of hearing voices is so powerful, is so immersive, right? That we need equally as powerful and immersive of an experience so that the individual is able to correct their beliefs, right? So we're going to learn through experiences versus trying to just talk somebody out of what's going on. The experiences for learning, right? Because if we really think about what is cognitive restructuring, it's really just learning a new lesson about myself, others, the world, the future, right? The idea of maybe I do have some control over these things, right? And at the end of the learning process, we want them to try something different, right? So we're going to learn all these different things, and then we're going to try something different in exchange. And so the beliefs that we've just talked about are what maintain the strength and frequency of the voice hearing experience, not some sort of biological misfiring, right? So we're really going to look at sort of those three behaviors: the isolation from control, the attention from credibility, and the sort of compliance or neutralizing from power. And we're going to look at those mechanisms as what's strengthening and maintaining the voice hearing experience. So that's when we get into this idea of CTR, right? And I'm very excited that I feel like I'm kind of on time, which is really cool. We're going to have lots of time for the interventions and a good amount of time for questions. So please, if, as we're at sort of the middle mark right now, if you have questions, please get ready to ask them. You can even start putting them in the Q&A section. So I love getting people's questions. So when we're talking about this protocol, right? Remember I said activation is this idea of getting people up and doing things and going. Aspirations are these future focus, those things that we want to be doing, the big picture stuff that motivates all of us to do things in our lives. And then action, right? Getting to doing and doing those things right now. These are going to be the mechanisms by which we create an experience to correct those beliefs that we just talked about. Low motivation and connection, though, is going to block all of this work that we're going to do. So we really need to get people motivated. And think about it. If you woke up every morning and you heard this voice just saying, ugh, you know, everybody really doesn't like you. You know, you're a pretty bad guy. You're pretty ugly. How motivated would you be to get up and do those things that you want to do? Not very. So we're going to really focus in on this idea of motivation, and it's really sort of building up those sort of internal engines that we have. So let's talk about activation, right? So what activation is, and right, that's the times where if you've ever talked with an individual that you serve and you kind of just get tired of you know, you ask them, like, have you been taking your meds? Did you go to group? Did you, you know, all those things, and you get these one-word answers, yup. Yup, nope, yup. And so all of a sudden you sort of just get tired of asking those basically like patient-oriented questions. You just sort of give up and you go, ugh, so tell me, how do you think the Cowboys are going to do this year? And all of a sudden this individual who has not spoken to you once just gives you a dissertation on, you know, the coach and what he needs to do and what's the next job and all of this stuff, right? And you're like, what? Like, it's really sort of confusing to see. You're like, where did this come from? So it's not that the individual won't talk to you. They just won't talk to you about what you want to talk about. But they'll talk your ear off if you talk about the Cowboys, if you talk about cooking, right? If you talk about, like, you know, which masks are comfortable, which masks are not comfortable. Right? You talk about places that you want to travel and whether you ever want to visit Nashville, right? Like all those things a person will talk your ear off about. So the reason we want to start with this is that talking behavior that we're thinking about right now, it reduces the interference of the hallucinations. Remember what I said before? My mom told me a long time ago, Aaron, you can't talk and listen at the same time. So if I'm talking, that's the time I'm least likely to hear my voices. So we're also starting to establish this idea of there's things that can make your voices less. So a lot of times I'll start my sessions off in the first ones when I've got a really serious voice here. And about 10 minutes into the session, I'll say, you told me that there's these things that bother you, that they really kind of stress you out. They're hard, you know, they make it hard to hear. He goes, yeah. We've been talking for like 10 minutes about football. How much have they been bugging you? I haven't heard them the whole time. I'm like, that's weird. We should pay attention to that, right? And so that idea that we're starting to establish that there may be things that can make the voices less, and there may be things that can, if there's things that can make the voices less, there are things that can make the voices more. But if I can identify what makes them less and what makes them more, then we're starting to build up this idea that the person might have control over the voices. So we want to sit here and strategically increase the individual's participation and motivation, and that idea that we're going to interfere with that voice hearing experience. Use as much media as you have available to you. So some of our favorite: cats with lightsabers, chickens with pants on, goats that scream like humans. I think my daughter just told me about ducks that wear boots. And then my favorite is Taylor Swift singing with goats that scream like humans, right? As much multimedia. Listen, the one thing every clinician on this video has right now in going for you is we live at a time where we can pull up anything on a phone or an iPad in about 2 seconds. And so we have so much material at our fingertips, even compared to when I started developing this treatment with Dr. Beck. I have so much more at my fingertips, and I can pull those things up right away. And so the goal of all of this is just for the person to notice, those voices are a little bit quieter now. That's weird, right? Because if you notice that enough times, maybe we can figure out that there's a connection to why those things are the way that they are. That leads us to aspirations, right? And so the reason we talk about aspirations in CTR is that the individuals we serve have been goaled to death. I think if another person asks them what their goals are, they are going to just, excuse my French, throw up in their mouths, right? It is, everybody asks them. I once was talking to this young guy and I said, well, we're talking about, we're in like a treatment team meeting and they kept asking about his goals and he says, I don't have any goals. And I started talking to him about he wanted to do construction, right? And particularly like finished plumbing. And I said, well, what would you call that? And he goes, that's what I want to do when I get out of this place. I said, well, then what's a goal? He goes, that's what my treatment team makes me do, right? So like the individuals we serve have been goaled to death, right? So what we want to do is find these bigger picture things, these aspirations, right? I want to teach my, I want to teach my daughter how to throw a football. I want to teach my son how to cook matzo balls, right? Like those are the things that sort of drive us. I want to go on vacation. I want to see the Alps, right? Like all of those things. Those are the things that drive us, right? And that's what's going to work with hallucinations, right? The thing about aspirations are when you set your eyes on the mountain that you want to climb, some of the things that the voices are saying don't really make sense anymore. Right? Especially once you start making a little progress toward that. Let's say I get a little coffee can and every time I go out, I drop some coins in there. If the voices keep telling me you're never, ever gonna get to, you're never gonna get there. You're never gonna get to travel and see the Alps. I could just start going, I don't know, my coffee can jingles a whole lot, right? And so all of a sudden I've got this concrete evidence to start countering some of what the voices are saying. And it also establishes a reason for working on the voices. My guess is to see all of you guys on this video today, you all really get it. You get it that these experiences are distressing and they hurt, right? And they're scary. Right? They're really scary for many of the people that we serve. And so the idea of pushing against it and fighting these bullies that the voices really represent, or that they sort of act like, it's terrifying. So the individuals that we serve have so much courage in going and doing that. So the aspirations are the reason why. You know what? If I can stand next to my daughter and give her a big hug on her first day of school again, well, you know what? I will get out of bed, even if they say the FBI is outside that door and they're going to kill me. Because you know what? It's more important for me to take that first day of school picture. And so it gives us the engine, the carrot that we're going to go toward. But it's those big picture things, right? How many people here would fight their worst, scariest enemy ever so that they could shower 3 times a week? It's interesting. You guys have gotten really good at raising your hands. I don't see a lot of hands going up just so you could shower 3 times a week. Although I would imagine some people out there are like, I love my shower. But you know what I mean. And so that leads us to action, right? So action is that ongoing stopping, lessening, of it, right? So it's sort of the old idea that busy hands are happy hands, and idle hands are the devil's play tools, right? So it's this ongoing contradiction of the voices. We can actually create sort of voice incompatible times, right? So if I wake up in the morning, I put on my headphones and I listen to music, well, I really probably am not going to be hearing my voices when I do that. You know, if I go outside and I train my puppy dog and I play with her for a while, right? I'm probably not going to be listening for the voices because I'm playing with my puppy dog and getting her to sit, hopefully. So that brings us to this idea of activity scheduling. And I know, so here's the bad news, right? The bad news is if you were hoping to come here and hear an intervention that you've never heard before in your whole life, and something that will shake you to the bones and alter the way you do therapy completely, I've got bad news. We're going to talk about activity scheduling. But if you were really freaked out that you would never be able to master a brand new intervention because you've never heard of it before and you were freaked out, I've got good news. It's activity scheduling. So activity scheduling is the systematic evaluation, increase, planning, evaluation, and increase, and then monitoring of the voice hearing of activity. With the idea that as we're doing more, we're gonna have more, we're gonna have less time to be listening to our voices, right? We're gonna have increased motivation and energy, so we're gonna get doing more stuff. And with that comes decreased psychosis, or at least decreased time for psychosis. And then we can start connecting that some activities are connected to less voice hearing. And if some of the activities lead to less voice hearing, well, who has control over whether they've done the activity or not? Me. Me as the individual. So here is one of the nice ways to start it off is we can start with a nice structured day versus an unstructured day. And we just sort of take notes of it. Because usually somebody, or the individuals we serve, have some day where we get sort of like schlepped around and have to do a whole bunch of stuff. And many of the individuals that I serve usually have some days, especially early on, where they're doing nothing. They're just staring at their wall. At the end of it, we can say, basically say, which day were the voices more? So here's just a quick video demonstration of it, and I hope it is useful.
Let's look at 2 days and compare them. So, what day did you not do much this week? Okay, yesterday? All right. So what did you do for most of yesterday? Okay, you're pretty much in your room all day. Okay, that's a good example of not doing much. Well, it sounds like Tuesday was pretty busy. So what did you do on Tuesday? Oh, you started by exercising. That's pretty cool. And then what? Oh, wow. So you walked the whole way? Well, that's pretty cool. That old man is nice. Oh, was he helpful? Okay. Well, that's really cool. Hey, you got to catch up with the crew. That's nice. And then you talked on the phone late at night? Oh, that's really cool too. Wow, that is a busy day. So just to summarize, yesterday, you pretty much stayed at home the whole day. But Tuesday, it seems like you woke up, you got some exercise in. Then you went to the doctor and got a chance to meet with him. And then you met up with some friends a little bit later on. And finally, you got to talk with your team later on at night. Which day did your voices bother you less? The day when you stayed at home, or the day when you had all those activities? Right, the day when you had all those activities. Interesting. We should pay attention to that.
So again, and I think I saw in one of the, I was scanning the chats a little bit while the video, because I've seen that video before. And so one of the interesting things about it is somebody had said that sort of old interventions become new. And listen, I think the person we credit is Dr. Beck with that, right? So Dr. Beck is, 99, it just turned 99. And it really was that idea of We applied it to negative symptoms. I'll talk about this tomorrow. And so we applied this intervention in negative symptoms, and we found that activity scheduling worked, but really even the Brits were using activity scheduling for voice hearing to help to demonstrate that the voices are controllable. And so, but it's just, activity scheduling has always been such a versatile intervention. So that's the reason that we're going to use it as this go-to. So the other piece that we're going to start doing, which is a little bit more specific to, well, it's not a little bit more specific, but it's going to be focused on voices, is this rationale for refocusing. A really brilliant psychologist out of the UK in I think the 80s did some neat research, some interesting and really profound research, that when you teach an individual to distract them, him or herself from the voices, that they become depressed. And so what we're going to be talking about is refocusing. And if you think about it, the only solution you had was to distract yourself for the rest of your life, that'd be pretty depressing about the idea that the voices have that much control over everything. So that would really that would get me depressed. So we're going to talk about refocusing. We're going to take our attention away from the voices and put it into the things that we want, right? Namely, the aspirations. So any technique that can help to shift the focus away from the experience will reduce the distress. But this is another great thing where these are going to be techniques that you guys already know. So it's great to take something that you're already really capable in and apply it to the voice hearing experience. And I think the other reason I love that approach is that it also normalizes it for the individual. It isn't that we're going to have to find some other really weird, esoteric intervention because this individual's so broken. It's going, hey, this is what's healthy for all people. In all reality, my friends who are executive coaches, all the time, they use activity scheduling, right? They use refocusing for CEOs and stuff like that. They just put it on more expensive paper so they can charge $350 an hour. So I think it's a great way of normalizing that the way we get back to being okay is to just be okay. So any technique that shifts the focus away from the experience will reduce the distress. Stress, fear, frustration, anger, other distressing emotions like shame and guilt or disgust are going to block activity. This is the basis of avoidance. But activity is the key to combating these experiences and ultimately achieving the aspirations. So that's where we're going to start using these ideas of engagement and activation, right? So using activity, communication priming, any of these things that are going to draw our attention away initially. So here's just a nice little list of refocusing ones. Things like headphones, iPods. It's a great thing because if I can put on my headphones and go out for a walk, I start reducing the voices. Games that are refocusing, like look, point, name, or any of those sort of refocusing tasks that we've sort of learned that are thought of as coping skills, those are going to be useful. Singing, speaking under your breath, doing some sort of mindfulness or focused eating. All of these are going to sort of refocus. But what we want to help the individual learn is I'm going to do this activity and then drive myself into what I want to do. That's the key to refocusing. Otherwise, we just sit there and distract ourselves and we become more depressed. So psychoeducation, when we're thinking about the psychoeducation, I always think of psychoeducation as a scalpel, not a hammer, right? Or not a sledgehammer. So consider psychoeducation as a very specific intervention for the individual you're serving. So if a person really wants to know, right? Or if they have these beliefs that their brains are broken and that there's nothing that can help them, and that they're super ill, if they have a lot of fear around the voices. Also, every once in a while, people who I talk to just want to know, like they're sort of like right on that cusp and they're like, well, what is it? And I usually play that very tentatively. I was like, listen, I'll answer your question. This is what a lot of people who I work with say, and this is what they find helpful. So here's a couple possible models to explain it. So there's sort of overconnection of the part of your brain that produces speech and the part of your brain that receives speech, and that might be it. It could be like a false positive, kind of like the motion sensor lights on the outside of your house. So it's just sort of a lot of these false positives. And just saying, you know, lots of people do it. 1% have schizophrenia, but 8 to 10% hear voices on a regular basis. You want to just make sure and keep your eyes open that the person's not becoming defensive and saying, no, no, these are real. Because then we're just in this power struggle, and then the individual's not engaging you in the conversation. So that's why if you really think about this, if you listen to the protocol here, it really is, there's no part of it where you have to discuss that these are a symptom of your schizophrenia. So thank you so much. If you've enjoyed today, if you go to Recover with CBT, I think I have like 17 webinars that I posted. There's no cost or anything like that. I just want to get the information out there. With that, I'm going to stop sharing, and I would love to get some of your fabulous questions. Thank you for being so attentive.
Thank you. Thank you so much, Dr. Brinen. Great, great presentation, great information. I was kind of also peeking at some of the feedback. Lots of comments, lots of questions. So I just want to thank you, Dr. Brinen, for sharing your expertise. We do have a lot of questions in the Q&A pod, so I'm going to go ahead and hand that over to Miriam Flory. She is an LPC, LPHA with the Compass in Denton County. She is the team lead for their FEP program there. So Miriam, take it away.
Thank you, April, and thank you, Dr. Brinen, for a really engaging, informative, but still very approachable presentation. So that brought about a lot of questions, and we'll get right to it. All right, Jack asks, can you expand more on the difference between goals and aspirations? How are long-term goals different from larger aspirations?
So I think it's anybody who knows motivational interviewing, there's the concept of the spirit of motivational interviewing. And so I think in a nutshell, there are still long-term goals that are hooked to essentially a patient-focused mode, right? So a lot of times people can say long-term goal would be successful maintenance within the in the community, right? Aspirations really have this feel of all the things that motivated us when we were younger, all the things that really excited us, and so that's the that's sort of the view of it, and they're really personal. They come from within the individual, right? And so that's the other part of it, is that they're really personal for the individual.
Great. Carmen asks, it has been commonly assumed that if the location of the voices are outside of the person, it is not considered authentic. How does Dr. Brinen view this?
The question of where the voices are inside the brain, inside the head, outside the head, I just don't. I think it's almost like a red herring. I think it's just it's a route that we don't need to pursue. I mean, that in just sort of its simplest form. I just treat the individual, and ultimately it's about just getting back to what you want to do. So a lot of the work is not about focusing in on the voice. A lot of the work is about focusing somewhere else.
Gotcha. Melanie asks, would you say that individuals have to come up with the solutions from within and not the suggestions that come from the professionals? Can you elaborate on that?
That's a great question. I actually, while we were getting reintroduced, I was peeking and I saw your question, Melanie. So that's a very cool one. So yes, I think you're totally right that it has to come from within the individual. Clearly, I think hopefully the energy of my presentation has shown that I'm not a particularly patient person. And so like sitting around and waiting for stuff, whether it's voice hearing, whether it's problems with drugs and alcohol, I'm not like, we can help it along, right? So I think that's the art of what we call collaborative empiricism. You know, if you've ever heard Beck do therapy, and if you haven't, I suggest like looking up a video of him online doing it. But Dr. Beck is amazing. And the more I got to know him, I used to giggle because I would be taking notes so I could help sort of explain what happened afterwards. But like right at the beginning of the session, I could see, or the intervention or the session, I could see him put the little pebble on top of the mountain that he poked. And then amazingly, he ended up exactly where his mind was going. And it's not about manipulation, it's about asking the right series of questions so that it's called guided discovery, not random discovery. So we do the guiding and they do the discovery. One of my trainees in Oklahoma came up with that and said that.
Great. Latrice asks, what if your client can't identify an aspiration? How do you help them get there?
Sure, and I think that's more of the core of like how to do CTR. The reason why you saw that it like an arrow is that it's very, the intervention happens as a protocol. CTR stands for recovery-oriented cognitive therapy, right? But when we originally came up with the name and everybody was calling it ROCT, they kept calling it ROTC. And everybody that we presented it to wanted to know why we were sending all of our individuals off to the military. So I suggested there was CBTI, which is insomnia CBT, and so there's CTR. So what was that question again, Miriam? The one I was supposed to answer?
I'm sorry, I just moved it over. It was about giving, I apologize.
Oh my gosh.
I'm going to ask a quick question to fill in the time so we're not wasting time, and I'll go back and find that. Would activity scheduling work for delusions?
I'll answer that one. That's really easy. Yes, and I found the question, so I fixed it. And so big apologies, Latrice. So yes, it works for delusions. I think if you think about sort of delusions are more of a belief, so that they're much more largely encompassing, but activity scheduling works really well because it gives the short answer is it gives a competing focus for it. So Latrice's question was, what if you can't identify an aspiration? And so CTR, recovery-oriented cognitive therapy, the protocol, the reason why we placed it in an arrow is that it's really directional. So if a person's giving you a lot of I don't knows, it means that they're sort of not activated enough, right? So we need to go back to activation and really get them in that zone where they're seeing toward the future. Think about a time when you've come home on a Friday and you've worked doubles all week, and if you're the person with the cell phone, your phone's been blowing up all week long, and you're absolutely exhausted. If somebody says, what do you want to do this weekend? You're like, I don't know. But then all of a sudden, if you walk in and you walk into the kitchen, your favorite song comes on. Mine's a Zach Brown song. And my daughter comes in and she goes, Dad, oh man, the tomatoes just came in. And she grabs my hand and we go out and we pick some tomatoes and we pop them in our mouths. All of a sudden I walk into the house being like, okay, this weekend, Radnor Lake, we're gonna do it. I'm gonna pack the bags. My brain's just as dead, but now all of a sudden I have all of this energy and focus forward. But it's the activation piece, right? Music, tomatoes, talking to my daughter. That's what's driving me forward.
I believe we have time for one more question, and this comes from Donna. And they ask if there's any specific advice for family members of individuals in first episode psychosis programs. And I'm assuming that this comes from a point of view of how can family members use some of these techniques with their loved ones?
Sure. I think I think a lot of it has to do with really validating the experience. I think as a parent, and clearly, I don't know if you guys have picked up, I'm a parent of 2 kids who I love to death. That at the core of the experience of being a parent is making sure that your child is okay. And the moment something goes wrong, even small, I was running around trying to get my kids on e-learning this morning so they could start school in Nashville on day one. And so I was running around squatting in front of their computers trying to log them in, you know, a minute before I was supposed to get onto this. So I get it. You take that and place it into the concept of psychosis. There's no book there's no chapter in the book, What to Expect When You're Expecting, that says when your child develops psychosis. So you're dealing with a group of parents who are rightfully so just terrified for their child. They may have already run into the professional who said, you know, listen, just expect that essentially kiss your baby goodbye. They're going to end up in an institution for the rest of their life. So all the dreams you had for them are gone. And so what a lot of parents start doing is they want to do all of this. Like a lot of times they're driving toward like, I can help them understand the delusions aren't right, or the voices aren't real, and all this stuff. And they jump into being like a 2-person or a 1-person act team, or first episode psychosis team. And so I think one of the great gifts that you can give to families is that part about activation. I don't know if you saw the slow motion fire, and we'll talk about that a little bit more, is the more parents get back to getting them active in doing stuff. Parents can be like, if you've ever been to Costco and there's all the little tasters that you can go and try out when you walk around, they can do that like with activity, right? So maybe the kid's going to be like, I don't want to talk to you. I know you're going to poison me. And be like, okay, cool. So I'm repotting all of these succulents right now, but like, if you want to help, great. Or you can go, they're going, I know that you were listening in on my conversations, being like, okay, cool. I'm just making dal, right? And you make these smelly, wonderful things. And the families can just do all of these activities side by side. And then you just invite the child in, or child sometimes being like a 40-year-old, but still inviting your loved one in. And so that you give them stuff to do that are voice incompatible, delusion incompatible. There are 2 webinars on my website where I talk about, one, how you can work and help families, but then there's actually one that I did for families for NAMI, and you can actually see that one as well. So I love peers too. They're some of my favorite